Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Thank you to our sponsors, Altum Dental Lab Group and RDT Dental Lab in Toronto. Hello, everyone. Welcome back to the podcast. So grateful for you to join us again. And today we have a very special guest, my friend, Dr. Gary Glassman, an endodontist in Toronto. And at the end of this podcast, you're going to learn about case selection and how to improve your endodontic cases so that you can do endodontic stress-free and provide better outcomes for your patients. And Gary, welcome to the podcast.
Thank you. Thanks. It's great to be here.
Oh, we are thrilled to learn from you. So, Gary, tell us about yourself.
Well, I am a full-time practicing endodontist, and I've been practicing for decades now. I think at last count, I've probably done about 60,000 procedures over my almost 4 decades as being an endodontist. I graduated in the 80s from University of Toronto, and I went back to endo school to Temple University in Philadelphia. At the time, there was no endo school in Canada. And believe it or not, there were only 35 endodontists in all of Canada at the time. I think there's probably 35 endodontists in the greater GTA right now, in the greater Toronto area, right? So I loved endo because I wanted to be an expert at one thing. And I used the phrase that I got from Dr. Danny Meyerson, if you all know, she's an endodontist, and she always said, endo is like going an inch wide, but a mile deep, as opposed to general dentistry, which is an inch deep and a mile wide. So I'm focusing on one thing really well. And that's why I wanted to become an endodontist. I think it was very challenging, and I still find it very challenging. No case is the same. And I like to be challenged during the day. So that's why I became an endodontist. Went to Temple University in Philadelphia, studied under the great Dr. Sam Seltzer, may he rest in peace, who wrote the book on endo, literally the dental pulp and endodontology. And my passion is education. I love teaching. I have a lot of programs that I give, 1-day, 2-day, 3-day programs. I have study clubs that I run specifically focused on endodontics. So it's something that I'm really passionate about, and I really love to do, teaching the future generation of dentists to become really skilled at endo, because it's a hard thing to become really good at, and you have to really practice it, and of course stay up on technology. And the key word is practice. If you do one a year, you're not going to become good at it. If you ask me to do an implant, I could probably do it, but it'll probably take me a very, very long time because I don't do it. And it's the same thing with endo.
Oh, wow. And that is quite a stellar career. And we're looking forward to your upcoming courses. And thank you so much for providing not one, but 2 in-person courses for the New Dentist Study Club in Toronto.
Of course.
And you mentioned challenging. Like, we find endodontics challenging because we're not doing it as often as you. And sometimes the cases are so challenging that we stop and we refer to our endodontist friends like you. So when you see those cases that other dentists have started, what are the most common reasons that things didn't go well?
Well, not necessarily don't go well. I mean, sure, I get cases where dentists perforate, or they separate an instrument, or they ledge the canal and block themselves out, and I sort of have to undo what was done and start all over again. It really starts at case selection before you enter a tooth, looking at the tooth, looking at the radiograph, making sure you take off angles. You're trying to, unless you have a 3D imaging machine, unless you have a CBCT, you want to try to 3-dimensionalize that 2-dimensional image by taking off angles. A bite wing is an amazing image to take because it shows the tooth in pretty real dimensions, not only mesiodistally, but apically, occlusally as well. So when you take a PA, if it's off angled, you may see what you think is a calcified canal, but you may have a really open pulp chamber when you take the bite wing. So preoperative assessment, visualizing how that case is going to turn out, what you're going to do in order to capture and leverage all the things you've learned and what good looks like. That's really, really important. So it all starts with proper preoperative assessment. proper diagnosis, making sure that you do all the pulpal tests and the periodicular tests, understanding the nature of that diagnosis, the restorability of the tooth. I often get cases that may have been started or may not have been started and get referred to me, but the teeth are non-restorable. So there's no point in going any further. So assessment of restorability, can you get your 1.5 to 2 millimeters of ferrule? Is there enough length on the ferrule? Is there enough width? Do you have more than 1 millimeter of dentin left in a root that may have been treated already? These are things that we have to look at preoperatively to determine the prognosis of the tooth. So preoperative assessment is really, really important. Once you get that preoperative assessment and you've made the diagnosis and you've decided, okay, I'm going to get into that tooth right now, one of the things you want to make sure that you do is you want to stay centered in the pulp chamber. You want to make sure you don't perforate, because that's something that I see, fortunately, not as frequent as I used to, but I do see it probably weekly where dentists may perforate, usually in the pulp chamber floor. So one way to avoid that, if you have digital x-rays, which most dentists do, or if you don't, because I know some dentists don't have digital x-ray, is take a measurement from the pulp chamber floor to the occlusal reference point. If you have digital, you can use the measuring tool and you measure it. Let's say, just for example purposes, you have a measurement from occlusal reference point, cusp tip, to the pulp chamber floor that's 10 millimeters. And when you want to make your access, we like to go right into the center of that tooth, right in the central groove. Make sure the tip of your burr, the measurement from the tip of your burr to the head of the handpiece is less than 10 millimeters, let's say 8 millimeters. So once you make your access, if the head of the handpiece hits the occlusal reference point, you know that tip of that burr is hovering over the pulp chamber floor. And then you can work your way out and expand your way mesially and distally in order to uncover the root canals that are on the chamber floor. So that's one thing you can do with access to help prevent a pulp chamber floor perforation.
That is so handy because I unfortunately did a pulp chamber floor perforation a few months ago, and I wish I knew that tip. So thank you. Yeah, take advantage of the digital x-rays and measurement.
Yeah, for sure, 100%. And then look at the pulp chamber floor anatomy. You know, you look at the pulp chamber floor and it's different than the walls of the pulp chamber. The walls of the pulp chamber are yellow dentin. The pulp chamber floor is this like marble-like appearance. You have the embryological fusion lines, which help point you in the right direction. So that's a great opportunity to look at the colors of the pulp chamber in order to determine where your canals are. And one of the things I always do, and I still do this after doing thousands and thousands of cases, when I access a tooth, I treat the canals I can find first. If I'm working on an upper molar, I just don't go zero in on that MB2 or try to shape all the canals at once. I'll leave the MB2 for very last, and I'll shape all the canals I can find completely. And then I'll go back to the MB2 for a few reasons. Number one, the MB2 is often the most calcified canal in a maxillary molar. And if you shape the canals you can find first, you get some work done. You get those out of the way. And now you can just focus in only on that MB2. If you got that MB2 in the back of your mind, like, I'm not going to finish the case. I haven't found the MB2. I've spent 20 minutes looking for the MB2 and I haven't gotten any work done on the other canals. You're going to stress yourself out. It's going to make it more difficult to find the canals. And now you're running behind and it's a stressful day already. So shape the canals you can find first, get some work done. So if you have to bring the patient back for a second visit, then that second visit is going to be way easier because all you have to do is focus on the task at hand. Using the MB2 as an example, find that MB2 canal because you've shaped everything else. Also, when you shape all the canals you can find first, what it does, it brings the orifices back into the original spatial position that they were when the tooth first formed. So it provides you with a better view of the pulp chamber floor. It really redefines the anatomy of the pulp chamber floor. And if you've shaped your MB and your DB and your palatal canal, it makes it way easier to find the MB2 because now you have landmarks to look at in order to orient yourself and redirect.
Oh, that's great. Yeah, the color, like, and then you feel like you got to win because
Right.
you're like, okay, I did the other canals. I just have to find this one little one.
Exactly. That
And you
MB
just and then
canal.
you bring them back and you just focus on that one canal.
Right, exactly. And another thing that I usually that I do, and I practice what I preach, is when I have a really difficult case, and I'll make no bones about it, all the cases I see are difficult. General dentist in North America does probably about 80% of all root canals in North America, and I see the tough ones, the calcified ones, the one that you can't even see a root canal on the radiograph. So what I'll do is I'll schedule those tough patients, what I consider tough. Maybe it's a retreatment with a post removal through a crown. I'll schedule that patient first thing in the morning, no consults around, nothing to distract me. So I can be, I love the term, being excellent in the moment, being totally focused on what I'm doing without outside distractions. And I find when I do that, number one, in the morning, you're freshest, right? You got your eyes are fresh, your hands are fresh, you've had a sleep. It's really nice, as opposed to scheduling that really tough patient at the end of the day when you're fatigued and you're tired. You're not going to do the best
Yeah.
job you can. And then you're going to end up bringing that patient back. So schedule the patient when you're fresh in the morning, no distractions around it.
Yeah, and also schedule yourself enough time so you're not stressed about, doing that recall exam or seeing the next patient.
No,
Yeah,
100%.
give yourself
Listen, I could, if I had no distractions and I had a really straight up easy case where I can actually see the canals on the radiograph, it would probably take me, 35 minutes to do the whole 4 canal molar, from anesthesia to access to obturation, even restoration of that tooth. But I schedule an hour and a half because number one, I want to make sure that if I do run into problems, ledges, I have enough time. If the patient becomes fatigued and they need a rest, I want to be able to give them a rest. So I want to build that in. And often you don't know until you start the procedure that the patient can't open their mouth wide enough or their jaw gets fatigued. There may be a clencher and grinder and they can't, keep their mouth open for very long. So even with a bite block in their mouth, they still need to have a little bit of a rest. Or I get an emergency, or I have an emergency consult, or I need to go and do a suture removal or a surgery check. That's the type of thing I don't want to run out of time with. So I always book an hour and a half. Usually book an hour and a half for molar, book about an hour for an anterior tooth. Anterior tooth, undistracted, nothing else around. Patient didn't need to take a break. I could probably do it in 15 minutes, but I book an hour. You always, like you said, great tip, Sanj, book more time than you think you really need. And if you finish that case before, you know what? Even better. Go have a coffee, call your significant other, and just, chill a little bit. Nothing wrong with that.
Yeah, that's right. So any other tips for, things that you see where GPs are having difficulties? You mentioned ledges. So why is it that we're ledging canals?
Well, one of the things you want to do is I'm a big advocate of establishing and maintaining apical patency. And what that means is repeatedly taking a small hand file, like a 6, an 8, a 10 stainless steel hand file, not a rotary or reciprocating NiTi file, but a 6, 8, 10, repeatedly 0.25 to 0.5 millimeters past the apical terminus, past where your apex locator says you are at the working length. What that does, it allows you a free pathway. In addition, you're instrumenting through a bath of hypochlorite, and any debris that you create during instrumentation, when you establish and maintain apical patency, that debris will stay in suspension and then be evacuated out coronally. That helps prevent blockages and compaction of debris. When you maintain apical patency, you are creating that pathway and you're maintaining that pathway, making sure that you don't ledge yourself out. Because if you go from NiTi instrument 1 to NiTi instrument 2 without maintaining apical patency in between, you don't know if that first NiTi instrument sequence created a ledge and NiTi instrument number 2 is making that ledge worse. It's easier to get around a small ledge than a bigger ledge. So in between, sometimes in between each pass of a NiTi file, let's say I go coronal third, I come out, I wipe off the debris, I go back into the middle third, I brush with it, wipe off the debris. Sometimes in between each of those passes, I'll take an 06 and 08 hand file and maintain apical patency. That is one of the tips that I really want to impart, especially on the newer dentist, the seasoned dentist, in order to stay out of trouble rather than recover from trouble. But that often helps recovering as well. So if you create your own ledge, put a small little bend on it, very, very gently, with a very, very light pressure on the handle of the hand file, sort of watch wind, quarter turn clockwise, quarter turn counterclockwise around the ledge. Once you get around the ledge with your hand file, keep the tip of that file just apical to the ledge, and like with little movements, just sort of sand away that ledge until you sand away that ledge and that small hand file flows smoothly to the apical terminus, and then take the next larger file in sequence. Maybe that was a 6, go with the 8, do the same thing, then a 10, maybe a 15, and then go back with your NiTi files, because NiTi files don't like sharp curvatures. They like smooth flowing curvatures.
So you're fixing the ledge with those tiny stainless steel files.
Yeah, stainless steel hand
Right.
files. Yeah.
Okay,
Sometimes
good.
I may want to use a C file, depending on the case, depending on the ledge. C files have the same dimension of stainless steel files as an O2 taper, but they're stiffer. And
Okay.
if you put a little curve on it, when you go around, try to get around the ledge with stainless steel, sometimes they kink and bend, as you probably
Yes.
experience. And then you got to toss it out and you got to get a new one. So
Okay.
the C files are a little bit stiffer, but every time you take a file out, whether it's stainless steel or nickel titanium, you want to examine the file. So this is one way to prevent an instrument from separating. Don't go back in with a file that's untwisted or a file that's stretched out, because that file could end up remaining in that root canal.
That's a great pro tip to use those tiny stainless steel hand files. But you mentioned going a little bit past the apex. Why is that?
Because you want to get a nice flowing glide path right to the working length. You don't want to compact debris. So if you don't maintain apical patency, you can compact debris and you may not get to length again. Right?
Okay.
And then you're compacting sometimes necrotic debris that's got bacteria. So when you maintain apical patency, you're gaining a whole bunch of benefits: better tactile control, less compaction of debris, less extrusion of debris, especially when it's flooded with hypochlorite. Now it's interesting because one would think, which may be top of mind for some, that if you're taking an 06, 08 hand file past the apical terminus, 0.25 to 0.5 millimeters, that the patient's going to experience more postoperative pain. In actuality, it's the opposite. Dr. Anna Arias, and I can send you a link for her articles. She's fantastic endodontist. She did a bunch of studies. She actually found with statistical significance that when you maintain apical patency in a necrotic tooth, that with periapical lesion, that postoperative discomfort is actually less when you maintain apical patency. She found with vital teeth, it's no difference, but you're gaining all these benefits by maintaining apical patency, preventing ledging, preventing veering off and maybe even perforating, preventing extrusion of debris, preventing compaction of debris, and allowing that
Okay.
debris that you're creating to be evacuated out coronally.
Thank you. And is there a minimum time that we should be rinsing the teeth with sodium hypochlorite, like irrigating? Because you mentioned that you could do interior in 15 minutes.
That's a great question. So years ago, when I first started, there were no NiTi files. We weren't shaping canals in 7 minutes. We were using hand files and Gates drills, and it would take us an hour to shape the canal. But during that hour, that sodium hypochlorite was soaking into the roots, and you were actually getting cleaning while you were shaping. Now we know that when you're shaping these canals really, really quickly, the hypochlorite doesn't have a chance to really percolate in there and kill the bacteria, get through the biofilm, get rid of the bacteria. So we really have to, during instrumentation, I instrument through a bath of hypochlorite, and I actually use ProLube to act as a lubricant. ProLube is a viscous chelator. It's like RC Prep, but it's water soluble. It has urea peroxide and 11% concentration of EDTA. There are some file systems that have really, really tiny wound up flutes that you don't want to use it because it tends to block the files. But in the systems that I use, whether it be Reciproc or ProTaper Gold, I find that's not the case. So I dip my files in the ProLube, I instrument through a bath of sodium hypochlorite. So I'm cleaning the canal during instrumentation, but it's not long enough. So we really concentrate on our final irrigation protocol. That's what's going to make or break a case. It's interesting. The one thing that you can't see on an x-ray when you evaluate the quality of the root canal treatment is how that doctor irrigated the root canal. You may see that the obturation is to the apex. You may see a beautifully tapered preparation. You may see a really dense fill and a fantastic restoration, but you don't know whether they use sodium hypochlorite or sterile water or tap water. You have no clue. So the protocol that a lot of endodontists use is a protocol of irrigate with sodium hypochlorite, fill the pulp chamber in your canals with sodium hypochlorite, and then use an activation method. One of the most popular activation is something called the endo activator. It's a dense Serona product. You can also use passive ultrasonic. You can actually take a gutta percha point and just vibrate it up, a well-fitted gutta percha point up and down that canal to agitate and activate the irrigant. So
Wow.
yeah, so that's the least expensive way.
The
So
endo activator hack. Use gutta percha.
there you go. If you don't want to spend the dough, but irrigate, sodium hypochlorite, activate it for 60 seconds. That'll remove the organic component of the smear layer, that inorganic, organic layer that's created on the wall of the root canal. Then you follow that up with EDTA, a 17% aqueous solution of EDTA. There's many products. Then you activate that with the endo activator, keep the tip about 2 millimeters short of the working length for about 30 seconds. That removes the inorganic component of the smear layer. And then I do one last rinse of sodium hypochlorite. I use full strength. Now that the smear layer has been removed, that last rinse of sodium hypochlorite will really clean the dental tubules, lateral canals, accessory canals, and get a nice clean wall. Then the last thing I do, which most dentists don't even know about, based on science by Jorge Vera and Philippe Sleeman, they use ice cold sterilized water as their final rinse. And I've been doing that for the last couple of years. And what that does, number one, it removes the chemicals in the canal. But number two, what it does, it decreases the external surface temperature of the root. So it acts as an anti-inflammatory effect. And
Wow.
that's the very last thing that I do. So to your point, final irrigation protocol is going to make or break a case.
That is incredible. So distilled, like ice cold distilled water at the end. After you did sodium hypochlorite, EDTA, sodium hypochlorite, and ice cold distilled water.
You got it. You got it.
Wow.
What my assistants will do the night at the end of the day, they'll take a plastic water bottle, they'll fill it up, usually about 3/4 of the way because it's going to expand, put it in the
Yeah.
freezer. And in the morning when we get started, they take it out of the fridge, out of the freezer, they warm it up in their hands and it'll start to melt throughout the day. And we pour it into a cup and draw it up in a syringe. And then we deliver it with a needle at the end of our procedure. But we leave it in the bottle before we use it because it'll warm up to room temperature very quickly.
Well, that's great. That's another poor girl trick, using ice cold sterile water.
There you
I
go.
have my own like makeshift endo activator now. Wow, I'm learning lots from you.
But you got
It's
to go in
scary.
that gutta percha point. You got to go up and down
Yes.
really for like 50 times.
I will get an endo activator eventually, but I'll
Yeah,
use that for now.
for sure.
Now, Gary, I had this very interesting situation where, I recommended endodontic treatment to my patient, and she's like, no, because I heard root canals are bad for your body. So what do you say to patients who say that?
Yeah. So I can send a bunch of links on that on how to communicate effectively with your patients. Unfortunately, it's misinformation that's been promulgated by a flawed focal infection research. It's called the focal infection theory by a Dr. Weston Price in the 1930s. So basically, he stated that bacteria are trapped in the dental tubules and they remain in the dental tubules. And it's true, you can't get all the bacteria out of all the dental tubules. But basically, what the theory says is that these bacteria are continually leached out into the body and cause all kinds of horrible degenerative diseases, including kidney disease, heart disease, rheumatic fever, multiple sclerosis. So this decade with this old flawed research as his justification, like decades old, almost 100 years old, it's been recommended that patients afflicted with these conditions extract their teeth. And unfortunately, a lot of perfectly good endodontically treated teeth have been extracted for patients that are trying to find hope in curing their diseases. So, I mean, several examples of misinformation are cited in this movie. Now, some of you remember it. It was taken off of Netflix. It was called The Root Cause, and basically, what the root cause was, it was a documentary that followed an individual's experience with root canal treatment and the alleged systemic issues he claims that arose from the root canal treatment. And it's so much misinformation, unfortunately, that it's sort of like saying 90% of patients that, or 100% of patients with cancer drink water, sort of that analogy. So we know from sound scientific research over the last, we'll say, almost 100 years, that we know this is just not true. And what is true, though, that untreated root canal treated teeth, let's say that have periapical lesions, can cause inflammation in the rest of our body. And we know that inflammation is the bad actor in a lot of systemic diseases. There was actually a recent study that showed one of the inflammatory markers, and again, I can send you the link to that, C-reactive protein, was found to decrease in the patient's serum blood levels after root canal treatment was done on cases that had periapical lesions. So we know that it actually decreases. And we know that sort of link, the association also with periodontal disease and systemic health. And that's a big factor in it. So that's something that we need to ourselves be educated, and also how to transfer that information and communicate effectively with our patients that no, root canal is not the boogeyman. It's not the root of all evil, or pardon the pun, the evil of all root, but it's something that is sound and it's scientific. And as patients start removing these sound endodontically treated teeth, they're not going to get rid of the diseases. It's just not, So it's something that we need to look at, and it's something we need to communicate. The American Association of Endodontists, Canadian Association of Endodontists have actual talking points that the doctor can look at, and I'll be happy to send you that link as well.
Great. Thank you. Yeah, it'll be linked to, this podcast episode on Spotify and YouTube.
Great. Fantastic.
Okay, great. What percentage of your cases do you get a CBCT?
That's interesting. I'm taking more CBCTs. I recently watched a really great webinar, and his name is Dr. Bruno Azevedo, and you can find him at conebeamguy.com. Coolest guy ever. He knows everything about cone beams, and he's an endodontist.
That's the coolest name, Cone Beam Guy. I'll check it out. Thanks, Gary.
I've learned a lot of interesting stuff on this, on his webinar. And one of the things is X-rays don't cause damage to your DNA. 3D imaging, CBCs don't cause damage to your DNA. And it's not an accumulative effect. And it's something that we shouldn't be scared of. Of course, we need to take the precautions, and we need to, give good information to the dentist. But we want to get the information, and it's important. So any tooth that's had a root canal, which is 80% of what I see or more, I take a cone beam. I want to make sure I know exactly what I'm dealing with. And I don't want to guess. Maxillary molars, whether it's been treated or not, I'm taking more and more cone beams. I want to know what the anatomy is like. I want to be able to not guess how many root canals there are. If there's an MB2, I want to look for it, and I want to know where to look for it. If there's not an MB2 and I find that MB root canal is right in the middle of the MB root, I want to make sure that I'm not going to look for an MB2, because it may not exist. Although the AAE says, that the MB2 exists almost 100% of the time.
Yeah.
But, I'd be happy if I found it 90% of the time. So I'm taking cone beams more and more. And if I had my way, I'd take a cone beam on every single tooth. A lot of patients don't want it. We don't force them. We tell them why. But again, you need the information, especially for the diagnosis. And that's really, really important.
Oh, that's good. Now, most GPs don't have a microscope. Do you
No.
need a microscope to do a successful endo?
Well, I always use the analogy of root canal treatment is like working in a closet with the lights off, right? Because you are working in a very dark space. And with good light and good magnification, so you can see the pulp chamber floor at very best. Maybe if it's a straight root canal, very large, you can see within the coronal 1/3. But you want to not put yourself behind the 8 ball. You want to make sure that you can maximize your treatment by making sure you've got good magnification and good fiber optic illumination. 4.5 mag or more is absolutely necessary for endo. We use a microscope for every single case. So I'm working at sometimes 8 times mag, sometimes 16 times mag, depending on what case I'm working on and how I'm doing it. But magnification, fiber optic illumination is an absolute must. If you have a microscope, you're ahead of the game. If you have a cone beam, you're ahead of the game. During the day, I say during the week, or probably a week doesn't go by where I'm looking for a canal, I may take a cone beam mid-treatment because I want to see exactly what direction I'm going. You can see in a PA mesial distally where you're going, but you can't see buccolingually. And a very, very common location to perforate is out the buccal. So sometimes it's just a matter of redirecting a millimeter or two before you find the canal, rather than continuing on in the direction that you're going to end up with a catastrophic result.
Oh, good tip. So save money on the endo activator by using the gutta percha technique.
Mm-hmm.
Shaking it 50 times. But yeah, if you can get the CBCT and microscope, and you can use the
Yeah,
microscope for other things. You can use it for your restorative treatment.
everything. You can use it for
Yeah.
everything.
Yeah.
Yeah, absolutely.
So it's a good investment. So Gary, any last tips for new dentists?
Well, a couple tips. When you are starting out, let's say anywhere from 1 to 5 years, and you want to get to that maxillary molar and start treating molars, start off with simple cases first. Know what good looks like. Start off with simple cases. 1 canal teeth. Do it really well. Understand the concepts: access, shaping, irrigation, obturation, restoration of the endodontic treated tooth. Then once you're comfortable doing 1 canal really well, then move to 2 canals. And then once you do 2 canals, then move to a molar. And sometimes it's a mental game, right? But just think about a 4 canal maxillary molar as just being 4 individual one rooted teeth, one rooted canals. That sort of gets rid of the mental part of it and also allows you to enjoy root canal and become good at it. And I think also what is important, especially for new dentists, is to try to gravitate towards a mentor, someone that you can look to for advice. Get a group of specialists in your stable of specialists and relationships, because it's great to be able to fall back and count on them when you run into trouble or when you just need advice. So mentorship is huge, and I think that's an important piece of advice.
Oh, thank you, Gary. And thank you for being such a great mentor for all of us. Now you have some upcoming courses. Please tell us about them.
I do a big, well, it's a 3-day in-person program, and the Dentsply Sirona Academy. But preceding that, we send the doctors an access kit, and in that access kit, you get 18 3D printed teeth, you get a couple explorers, you get a burr kit, and instructions on how to go online to a program that Dr. Steve Buchanan and I are partnered up with, and it's an e-learn, and it's self-paced. So you go to your office, get your hand pieces going, and you make your access, follow along with Dr. Buchanan's e-learn. And takes you about 8 hours to do if you do it in the proper sequence. And then you join me 2 weeks later, you take photos of it, you send me the pictures of your access, I evaluate them, give you feedback, and then you join me 2 weeks later at the Dentsply Sirona Academy for 3 full-day intense hands-on on extracted teeth, on 3D printed teeth. We teach 3 systems. We teach Pro Taper Gold because that's a foundation system. We teach the newest Reciproc Blue, which is a reciprocating system. It's a one-file system 90% of the time. And we also, for those that want to adhere to minimally invasive endodontics, we teach a system called True Anatomy as well. So that's exciting. My next course is in June. If you go to clinicaldentaltraining.com. We do have a few seats left for our June course, and you can go online and register online for that and actually see the course outline and the curriculum which I have to offer. I also do one-on-one coaching and mentorship too. If somebody has taken my foundations course or they've taken a foundations endo course, you're eligible to do that. And you know, the one-on-one coaching is really, really valuable, especially if you want to up your game in endodontics. So you can reach me at gary@rootcanals.ca and get some more information on that.
That is phenomenal, Gary. The format for that course is incredible. Doing it in your own office with your own equipment, and then getting the in-person training and then the one-on-one coaching afterwards. It's like, wow.
Yeah, it really, really ups your
Definitely
game.
gonna up your game.
32 CE points pretty much in one weekend.
Wow.
Yeah.
Thank you. Thank you so much, Gary. So many pearls. I learned so much from you. I really appreciate everything you've done for the New Dentist Study Club in Toronto and what you're doing for our whole profession. You're uplifting all of us so that we can provide better treatment for our patients. So it's a true honor.
Absolutely. And thanks for having me on the podcast. Really
Oh,
appreciate
you're welcome. And then please check out the show notes, the links. Gary's going to list some courses on Spotify and YouTube. So grateful to all of you for joining in. Please stay tuned for our next episode. Thank you all. And thanks, Gary.
Thank you. Have a good one.
This podcast is sponsored by RDT Dental Laboratory, your full-service dental lab in Toronto. RDT Dental Lab will help you grow your practice through education, predictable restorations, and high attention to your clinical needs and patient experience. Check them out at rdtdentallab.com. Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.